now have been just to help you through the process of getting started, if you like. So you start with your self-assessment, you then move on to your action plan if you want to, but the actual bit that probably is the nitty-gritty is the presenting your evidence. So we're going to do some work around that. We'll look at reviewing what the concept of evidence actually is. What do we mean by evidence in this instance, not in the whole greater scheme of things. We'll revisit the requirements for submission. I think that's probably an area that people would like quite a lot of clarification about. So we'll look at that. We'll look at ways in which you can collect and present evidence, and also look at how you might structure your portfolio. And we've given guidelines of all this in the manual. This is basically just going through it with you to make sure that you understand what we're talking about. So what's evidence? I don't know how many times I've been asked that over the course of the last weekend or two. But evidence is absolutely anything that you choose as an osteopath to submit in order to support your achievement of the revalidation criteria. So it's any evidence that you feel you would like to use to support your practice and to put into your portfolio. But this is the difficult bit, if you like. Your evidence must be relevant. So it must be relevant to the revalidation criteria and the themes, because that's why it's in there. So it might be a very interesting wee story about something, but if it's not relevant to the revalidation criteria and the themes, then there's no point putting it in.
I'm really sorry. I've kind of come to a brick wall in terms of, I've got my head around meeting all the themes. But why do you need revalidation criteria as well as evidencing your themes?
The revalidation criteria feed into the themes. So they're there to help you actually to address the revalidation or the themes of osteopathic practice. So they've emerged from your standards. Your themes have emerged from your standards, and then we took the themes and thought, well, what sort of questions do people need to ask about their practice to allow them to show that yes, they are doing this, and that's where the revalidation criteria came from. So it's basically to help you ask the right sorts of questions. And I know some of them aren't worded the right way, some of them might not be right. These are drawn. But it was to help you ask the questions that would then allow you to address all four themes.
The grid, it's the ones down the left-hand side, isn't it?
The ones in the middle, kind of in the middle, that's the revalidation criteria.
Oh no, I don't mean that.
Oh, sorry.
No, on your grid, later on, you've got something else entirely, yeah.
On the mapping grids?
Yeah.
Oh, on the poster?
Yeah.
On the poster?
Yeah.
Alex,
Okay.
hopefully that will become clearer.
Okay.
That was something we've picked up, that the poster grid bit has been slightly misleading for people. Okay, so I will clarify that, but thank you for bringing that up. So your evidence has to be relevant, it has to be authentic, and by authentic it just means that it has to be your evidence and not evidence that you've got off the internet or Googled. And now I know you're going to ask me, how do I know it's authentic?
Honesty.
You're professionals, you have professional integrity. But it has to be authentic, so it has to be about your practice, so there's no point doing it basically. Now I've heard this word bandied about already today about sufficiency. What do we mean by sufficient? Sufficient just means that there's enough there for an external person to look at and say, yes, that evidence demonstrates to me that they have addressed the themes and the criteria. It can be big, it can be small, it can be filmed, it can be written, it can be anything you want, but as long as you can demonstrate that there's enough content within your evidence to show that you've addressed the revalidation criteria and the themes, then that is sufficient. And I know that's a cop-out, but that's all you can say about sufficiency. And it needs to be current. And again, there's been a lot of sort of discussion around about what is current. If I was an educational establishment, and I'm not, I would be telling you that it needs to be something from the past 5 years before it's current. To me, anything that you're doing now in contemporary practice, whether it's based on something that was written 20 years ago but still relevant, then that is still current. As long as you're using it in your everyday practice, it's contemporary and it's current. Okay, so don't get hung up on this, I'm basing this on something that happened, 5 years ago or 10 years ago, whatever. If you're using it in your everyday osteopathic practice, it's current. Right? Okay?
Aren't there two types of current? I'm sorry, but these words are really important. Isn't there the knowledge
Mm-hmm.
and the research that we do and the reading that we do
Mm-hmm.
and the approaches that we use based on the education that we had and the history of osteopathy and the kind of legacy that we work with, and health sciences? Isn't there that whole issue of current, a word that is used within that context to apply to knowledge? And then isn't there current
That's really
applied to the evidence that we collect based on the patients that we see and the work that we're doing? In other words, if I saw a patient 5 years ago or 10 years ago and I want to use that as part of the evidence that I submit, is that still current enough?
if you could demonstrate to me how you've taken the learning from that experience and are using it in your contemporary practice. So I could take an example of something that happened to me, and I will, I mean in I dread to say this, but in 1979, I cared for my first dead patient. Okay, so it was the first patient I'd had who died. I did that with a very, very good South African staff nurse. I learned a huge amount from her. And the learning that I took from that experience, albeit 30 odd years ago, I still use in my current practice. But to have it as evidence, I would have to sort of explore, if you like, what I learned from that situation, and how it's still relevant and how I still use it. And that to me is current evidence.
So you wouldn't necessarily then have to be talking about the patient that you're seeing now. You could talk about your work then.
But you would need to explore how that's impacted on what you're doing now, because it is about your practice now, not about my practice 20 years ago.
And when you say now, are we talking about within the last 5 years? Because I saw 5 years written in this material somewhere.
I think that was for the evidence base.
But I saw 5 years written, and you just said 5 years, and I thought, yes, that's
Because
right.
5 years is the accepted, for things like research, etc., unless it's a seminal piece of work, 5 years is the sort of accepted currency for things like research and literature, etc. Okay.
So in other words, we could use some reference to what's happening now, but we could actually, a part of the body of what we submit could be about that experience,
Yeah.
for instance, that you had, and the bulk of it could be about describing that very significant moment of learning, or process of learning, and then just with some reference to how that impacts on our daily practice.
Yeah. Probably exploring rather than describing, or analysing rather than describing.
What's the difference?
Well, describing is just writing down exactly what you do without allowing people to see why you do it and how you do it.
But then part of what you said we do this morning, you said about describing what we do. So you said that that's valid as well.
That's part of it, yeah.
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 And what was the other current? You said there's 3.
No, you you said there's two ways of current, and then you came up with 3. For the requirements of the pilot, this is what you have to do. This is just for the pilot process. You have to have a piece of evidence or a body of evidence relating to each of the 4 revalidation themes. So somewhere in your portfolio, if somebody asked you to point out, and they will in the mapping grid, you should be able to say, I've addressed all 4 of those themes. So I've looked at issues around professionalism, I've looked at issues around communication, I've looked at issues around safety and quality, and I've looked around knowledge and skills, etc. So somewhere within the portfolio, these must have been covered.
Or could one piece of evidence relate to 2 themes?
Yeah, as long as you can map it, but you are asked to, they are asking for the purpose of the pilot for 4 pieces, separate pieces of evidence.
For the pilot?
Yeah, for the pilot.
Yeah.
Remember, this is about the process, not about the outcome almost. So 1 piece of evidence relating to each of the 4 revalidation themes, and of these 4 pieces of evidence, a minimum of 1 should come from each of the 3 identified categories. This is when it begins to sound really, I'm getting confused reading it. But within your 4 pieces of evidence, somewhere along the lines, you have to show that you have at least once looked at giving information, discussing practice, developing practice, and feedback and practice. And if you refer back to your manual, and that's also why I did that sort of précis, if you like, or summary of the pieces of evidence, that will show which types of evidence fit into which category, or the best way of addressing them. What happened was when we looked at the themes and we looked at the revalidation criteria, when we were looking at them, it certainly seemed to us that there were 3 different categories and different types of evidence that you might like to give. And those were things that were talking about giving information and discussing things with your patients. And others were more about developing practice, and others were about feedback and practice. So that's why we put them into the 3 categories.
What are the 3 categories? Can I just write them down?
They're on page 22 of your manual.
It's all on that summary piece I gave you as well. It tells you which pages of the manual to go to.
Page 23.
22.
So you have to show somewhere within your evidence that you've looked at these and considered these. You also have to include 1 piece of subjective evidence and 1 piece of objective evidence. And subjective evidence is things like self-significant event analysis, reflections, etc. Objective evidence would be more like your clinical audits, your patient satisfaction, or your patient experience questionnaires, etc. So 1 piece of subjective, 1 piece of objective. And then, and we discussed this with one of the groups as well, just really for the people who are looking at your portfolios, it's really useful if you also include some rationale why you included that evidence and which revalidation criteria the evidence relates to. So that's just for us to say, okay, such and such chose to do a significant event analysis. Why did they choose to do it? Why have they included it? You know, and what criteria has it been useful in addressing?
She said, where's it going to point it?
It's the next slide. I don't know if you can see that. I don't know if the colours.
It's on the back of the assessment handout.
This is just something, this has actually emerged from a lady at the 2nd workshop who suddenly went, aha, I know what they're talking about. And she wrote it down on a wee post-it. And this is what it basically said. And this was just to illustrate what you need to do. So you have to address all the 4 themes on the left-hand side. Those are the 3 categories, and they're feeding into the themes. So somewhere you have to show that you've addressed the 3 categories, and somewhere within all that you have to have 1 objective piece of evidence and 1 subjective piece of evidence. So 4 themes, 3 categories, 1 objective, 1 subjective, and how you choose to do that is completely up to you. But that's what you have to show. Okay? Does that make sense? No.
Confusing these
This is. Oh, see how this is. I thought when the lady showed it, I thought that was really good.
That's not too bad. But you know,
it is complicated. There's no getting away from it. It is complicated, but I think it's complicated for the purposes of the pilot because we're trying to get so much from you, and we had loads of discussion about minimums. Should we be setting any minimums at all, or should we just let people put in evidence? And we came up with 4 pieces because there was 4 themes, and it seemed to make sense. You know, so it can be confusing. I mean,
this is each month.
Sorry?
This will be each month, each 3 months.
No, this is the whole thing. This is the revalidation pilot. This at the end of the day is what you have to have done.
1 thing each 3 months.
Yeah.
Okay?
Yeah, and within that you should cover everything else.
1 theme each quarter.
It doesn't need to be.
It
Just
can be.
D&E.
Yeah, you don't have to do a theme each quarter. If you might like to do it that way, other people might take a different approach and might do 1 piece of evidence that covers elements of different themes. You know? I'll give you an example. Okay. Yeah, I think that's the sort of the quickest way to do it.
1 thing each month sounds much more. If you presented
That sounds much more manageable.
Do 1 theme each month, and in the meantime address each of those. But if you want to do it differently, you can.
Yeah.
A more clear way
One
to
theme each
Okay.
Okay, just each 3 months.
I'll be prescriptive then, if that's what you want. If you want to do one theme each month,
Each quarter.
each quarter, do one theme each quarter.
We don't.
If I'd come up here and stood up and said that, you would have said to me, you'd be very prescriptive. I'm going to do it a different way. So I'm not standing up and saying that. If it was me, that's the way I would do it. But I would also actually develop my first piece of evidence, and I think you'll be surprised at your first piece of evidence. I think you'll end up demonstrating more than one theme. And that's what will be interesting to see. So
I'm thinking of mine, thinking it's all 4. The thing that I've got covers all 4 of those, and I can't think how I can say.
well, yeah, I mean, can you share with us what you're planning to do?
Yeah, we were discussing about patient consent, and so I thought, as an old osteopath in the time when the consent was they came to see you. So whatever I did was, I do not ask, can I touch your hand? Can I touch your shoulder? Can I touch your leg? Can I do this? Can I do that? It's a case of now I'm trying to think of questionnaires that I can get my patients to complete before they come in for treatment and after they finish their course of treatment, to say what is appropriate consent, what do you feel is appropriate consent, of trying to think of a questionnaire that I can ask patients before they come in as a new patient and afterwards, to say what do you feel is appropriate, what level of risk do you want to know about, what level of questions about consent for this is appropriate to you. And then go to other professions, because I'm also a medical acupuncturist, and also find out from them, because a lot of them are doctors, what consent, I mean, yes, there's consent you have for acupuncture because you're sticking somebody with a needle, but apart from that, is the profession's perception of consent and aesthetics, as it were, of how you go through it, way over the top to what a patient actually appreciates. And are we asking too many questions?
Is that not a piece of research?
Yeah, sounds like research to me.
Because at the moment I would just want to do it as a small thing, because if I'm going to introduce this into my practice, then I want to know that it's actually something my patients want. And I've got massive amount of people coming into my practice. In 3 months I could get quite a lot of information out of that number of people, of the regulars who are regular osteopathic patients, of new people that have never been, and to actually ask them. I'm trying to think of a way, but to me that's communication, it's also knowledge and performance, it's also safety, and it's also professionalism. So it's almost, to me, that covers a lot of them. I don't quite know how I would, but
How you would evidence that?
yes, because it's a case of, it's the one thing where if I'm nitpicky, I'm thinking how could I prove that I'm asking? Because the level of what, and as Caroline was saying about current, my understanding of consent comes back from 1979 when I qualified. The consent that some of the new osteopaths are coming out with, I'm looking at going, what?
But it's probably based on legal requirements. I mean, so if I was going back, I think you could do everything with that. I think you would need to use different tools to do it.
But also it's going to the GOsC and finding what is the legal requirement.
Well, not GOsC. It's a legal requirement for informed consent. It's not GOsC.
But in 5% informed consent of what? To what level do you ask, may I touch you? May I touch you again? May I do soft tissue? May I do soft tissue here? May I do, I mean, at what level do you actually go beyond consent legally? This is one of the things I may have to inquire of. I mean, as an acupuncturist, I don't ask to stick in every single needle.
No, but when your patient came to you as a patient, you presumably, with that patient, came to you had a discussion about why she presented, you then presumably developed a plan of action of what you're going to do with this patient, so it wasn't just that you were doing everything without any consent. Within all that, you will have been explaining and communicating to that patient what she could expect in the treatment. So by the time you actually come to do the treatment, the consent, if you like, be it verbal, be it written, has already been given. But what you need to make sure is that she is involved and you have communicated.
But the younger osteopaths that I've been talking to are talking about, if I examine a hip, I ask permission to examine the hip. well, if you come in with a hip pain, I'm assuming you're going to want me to examine the hip.
Can
I mean, what I'm saying, the level of consent is totally different from my era to the new osteopath.
Yes.
And perhaps maybe certain colleges, because I certainly wasn't taught to ask for consent like that.
I think
We're digressing a wee
what
bit.
we've done, just consent's really important. It was quite a key part of the consultation in the osteopathic practice standards. And so it's in the back of your folders. You've got copies of the revised osteopathic practice standards. So it's the back of part 3. So these are the new standards that come into effect. Now, as Katrina said, consent is legal. It's based on case law, which it changes regularly, and it's important to keep ourselves up to date with what the legal requirements are for consent. And then standard A4 says you must receive valid consent before examination and treatment, and that's on page 5 of your osteopathic practice standards.
Valid consent. Well, I don't care what you do, mate. Just sort of pain out. Right, so you whack them. God, didn't know you were going to do that.
So what we've done in the guidance is kind of elaborate a little bit further what that means. So we say, for consent to be valid, it must be given voluntarily by an appropriately informed person. So it's your job to inform them. And also, they need to have the capacity to consent to whatever you're doing. So, and that goes on to there are different rules with regards to children in different parts of the UK. There's some really good guidance there. They've done a lot of work on that on pages 5, 6 and 7 of the guidance. But it is a difficult area, consent, and it is an area that changes because it's set out in law, in case law, and it's argued before the courts all the time. But it's definitely worth having a good look at that guidance there. And I believe it's one of the areas that we're looking to elaborate on in due course as well.
So that's going to be mine. No, that's fine. Oh, that's okay. And you could probably address all 4 themes, all 3 categories, because if you think about it, giving information, recording, discussing, that's the actual giving of the information to base the consent on. Developing practice, well, you're developing your practice because in
Obviously,
your practice before,
yeah.
you did something completely different, and presumably, you'll come up with something that now meets the legal requirements. And feedback and practice, well, you would have to ask, as you say, do some sort of thing with the patient, if you like.
After that.
Yeah.
Okay?
Yeah.
So you can. Everybody,
could check
I know,
the
I
patient
mean,
feedback.
I can see some confused faces. I will be coming round in a minute as well, so any further
Could you
questions?
just say something
Yeah,
on
you may.
D and E?
Pardon?
Subjective and objective. Subjective, on the poster it's A, B, C, D, E, but subjective and objective.
That's why we developed this, because we were finding that was slightly confusing for people. The subjective and the objective will just come somewhere in with this. They're not separate. You don't have to do 4 that look at themes, 3 that look at categories, and 1 objective, 1 subjective. You can address them all within each other. So that is kind of misleading because it makes it look as if they're,
2 extra.
yeah, it's 2 extra. There aren't 2 extra.
Yeah, okay.
Right, what we're going to do now is have a look at some of the tools that you can use to evidence your practice. Now, I said we put some templates